All right, everybody. Welcome to Grand Rounds. I think it's the coldest morning of the year so far. It's freezing out there. So this is today's CME code. Welcome to all the applicants. I will be speaking with you at 9:30, but welcome to Duke and to North Carolina. We do a little department news at the beginning. Tonight, an ALS documentary done by a patient of Rick Bedlack's is going to be on a variety of movie theaters in Raleigh and Cary, and will be online. It's called Go On, Be Brave, about how Andrea Peet became the first person with ALS to do marathons in all 50 states. That's amazing. I've done a marathon in 0 states, so very good for her. A little bit of Duke history for you folks, and Maria put this in the slides. I added it a little. In 1896, Washington Duke, who, as you all know, was the father, donated $100,000, which was a lot of money in those days, to the Methodist institution, Trinity College. Now, I know you think that's a familiar name, and Duke undergrads received their degree from Trinity College. It wasn't until 1924 that Trinity College was incorporated into the newly found Duke University, thanks to a huge gift from Washington's son, James B. Duke. As a condition of giving the gift in 1896, Washington Duke insisted that women be admitted and treated equally at Trinity. Note, that was before it happened at Johns Hopkins Medical School. And the other last thing, an earlier gift from Mr. Washington Duke, 1892, allowed Trinity College to move to Durham from Randolph County, where it had originally been. So a little bit of Duke history. And this is, as you all know, the 100th anniversary of the founding of Duke University. And undergrads, as I said, still receive their degree from Trinity College. And that's why Duke is a Methodist institution, or it was. Okay, this week's All-Star is Kelly Blessing, nominated by Hillary Yu. Hillary said she was seeing a headache patient who came in with her broken CPAP machine, thinking she could get them both fixed at the same time. And Kelly and Michael Garcia went and took care of the CPAP issue, even though they were there for a headache visit. So great to everybody. Tatiana Segura was featured in Becker's Hospital Review, looking at preventing orthopedic surgical infections. Sharon Feckrat talked with AARP, which most of you think is just impossibly far off in your future, but it comes quicker than you think, about the importance of a dilated eye exam every year in older folks like me. Greg Kogan was on The Street, which is a Wall Street publication, talking about his brain electrode implants and talking about the difference between Elon Musk's Neuralink program and Greg's program. Greg's in the news all the time now. William Alexander and members of the school's Office of Equity, Diversity, and Inclusion received a gold award from AAMC for the work designing their new webpage. Daniel Parker, one of our memory docs, received his master's from in clinical research from Duke, the clinician scientist program. Way to go, Daniel. And Janelle Montgomery, who we all know and is a pharmacist in the MS clinic and program, was the senior author of a review article looking at the role of pharmacists in a comprehensive MS program. Again, today's CME. And now we're going to hand it over to Brian Dahlben, who is this year's Movement Disorders Fellow and next year's faculty member, to do today's case. So, Brian, you should be able to take over the share screen. There you are.
Hopefully the video will come through, but so I've got a brief case to present, case in movement disorders. This is a 68-year-old that I saw with jaw protrusion. She complained of difficulties chewing and holding her jaw still. She said it started in 2018 and it's been mildly progressive over time. She describes it as her jaw kind of jutting forward, and that prevents her from maintaining an alignment as she chews straight down. So she's chipped multiple teeth because her lower jaw is forward. She's bitten her tongue. She's had to adjust the types of food, kind of favoring fattier foods that are easier to swallow. And so she's consequently gained some weight. She does not have any type of a sensory trick to go along with this. And she does have a tremulous component that gets worse when she opens her jaw. She's never had any type of a dopamine antagonist as part of her history, but she does have social anxiety, and that's largely in part due to these mouth movements that are a source of embarrassment. So she feels like she always has to have something in her mouth, so it looks like it's doing something on purpose. She has hard candy in her mouth in public. She was first seen by orthodontics. She completed Invisalign, and ultimately they determined she did not have a TMJ disorder. Then she was seen by neurology first in 2020. That time she was diagnosed with oromandibular dystonia. They did a Botox trial targeting the masseters and the temporalis, which are more for jaw closing. And she also tried some oral pills of Flexeril and Artane, which were not tolerated due to lethargy. She's been taking Klonopin as needed, which does help, particularly in those types of public situations. She takes up to 4.5 milligram pills at a time or per day. And this is what her movement exam looks like. So I'm going to keep the video and audio on. Hopefully it comes through okay.
And close your eyes.
So as we're seeing, she's having these constant movements. We'll see from a side profile what it looks like and how the jaw
I'm just going to film at an angle.
Not so much.
And then open your eyes.
Platysma activation.
Can you stick your tongue out?
But certainly she had that.
Move it to the right,
mentality.
to the left. And then give me a nice big smile as best as you can. I think that's tough.
Part I can't do.
Okay, and then relax. Okay. And then clench down as much as you can. And relax. That was just the teeth chattering.
Yeah, it was. Yeah, they were like grinding.
Right, and so these movements were not suppressible. They're involuntary. They were not tick-like, and she didn't have any other significant findings on her
Go ahead
exam.
and close your.
My impression for her was of the jaw protrusion subtype of oromandibular dystonia, which I'll talk briefly about. And the plan was to target the jaw protrusion with Botox. We also talked about appropriate Klonopin use and trying to limit that for safety purposes, and discuss some other oral options which are not as good as Botox for focal dystonia, and referred her to help with social anxiety. So oromandibular dystonia was first described in 1976 by one of the grandfathers of movement disorders, Dr. Marsden, as encompassing dystonic contractions of muscles of mastication and muscles of swallowing and muscles of the tongue. The mean age of onset is in the 50s, like many other dystonias, and it's a 2-to-1 female to male ratio. Just to give you a sense of the prevalence per 100,000 people in the United States, cervical dystonia affects about 5 individuals per 100,000. Blepharospasm is not far behind, and then oromandibular dystonia is 10 times as rare, affecting about 0.5 individuals per 100,000. And so a lot of these patients end up seeing a dentist, seeing an oral surgeon, and it's often misdiagnosed at first as a TMJ disorder or bruxism or just a psychiatric illness. These are the main types of oromandibular dystonia. So there's jaw closing, jaw opening, jaw deviation to one side. I have here highlighted the jaw protrusion dystonia, which is actually the rarest as compared to the jaw closing, which is the most common. Lingual dystonia is the last subtype. And on the right-hand side are the different types of targets that we would go for Botox, because these are the muscles responsible for those actions. These are the actual injection sites. So starting off in that first picture, that's the masseter and the temporalis, how we would approach it for Botox. Next is the medial pterygoid with the extraoral approach in the red arrow and the intraoral approach in the blue arrow, followed by the lateral pterygoids on the top right. The genioglossus muscle we can attack, as well as the tongue surface for a lingual dystonia, and depending upon whether it's a curling of the tongue, a protrusion of the tongue, or a lateral protrusion of the tongue, we can hit different of those 6 labeled spots. So As far as the lateral pterygoid specifically, because that's what would help for her jaw protrusion, that involves the superior and inferior heads, which reciprocally contract during mouth closing and opening, respectively. So that extraoral approach is highlighted here. And so that's a limited window, just because we're approaching from the outside. And there's a risk of dry mouth. So you just want to palpate that mandibular notch and go about 2 to 2.5 centimeters below that. Once the needle is inserted, then you activate the muscle by having them move their jaw to the contralateral side, as opposed to the intraoral approach where you're having them open the mouth. There you have a direct visualization, and there's a little bit wider area of the muscle to see, but maybe a little bit tougher kind of technically. So as far as follow-up, I saw her initially in about 2 months ago, and then just saw her back a couple of weeks ago. And we went forward with Botox of the mentalis and the lateral pterygoids with the assistance of Dr. Moore, using that extraoral approach and EMG guidance. So a total of 50 units. And so we'll see how she benefits from that. We can go up on the dose as needed.
Thank you, Brian. Beautifully done. All right, so it's my privilege to introduce today's speaker, Dr. Birgit Frauscher. Birgit is new to Duke, and we're thrilled to have her here. She's a professor of neurology and a professor of biomedical engineering. Her training and fellowships were at the University of Innsbruck in Austria, where she received an MD, PhD, and then did her residency and fellowship in neurophysiology, epilepsy, and sleep. She has over 150 publications in most of the highest visibility journals in the world. And her research focuses not only on epilepsy localization and characterization, but is someone who realized that in addition to thinking about neurons in the temporal lobe for brain function, she also utilized epilepsy patients to have a deeper understanding of sleep in the brain and how sleep and epileptic foci interact. It's a really incredible bit of research, and it's just beginning. And we're thrilled to have her at Duke and to have her speak today. So, Birgit, I'm going to throw it to you now.
Thank you very much for your kind introductory words, which I will share my screen. I find it. Just a sec.
That's what I love about Zoom. Birgit's got 150 publications in Nature and is having trouble sharing her screen.
I don't have. So now the only trouble I always have is, can you see the presentation mode?
Yes, we can see it great.
Screens. That's the issue. Okay.
Great.
So yeah, so today's lecture is about the bidirectional influences of sleep and epilepsy across space and time. And it first might sound very exotic, but I hope I can convince you at the end it's not. I have zero disclosures that I feel are relevant to this particular talk. And that is just an introductory slide, particularly for the learners on the call, and just to showcase actually that there are these multiple interactions between epilepsy and sleep. And I think you're a better epileptologist if you have a profound understanding of sleep, and evidently it would be also good for sleep docs to have a good understanding of epilepsy, because 50% of these patients would indeed have sleep disorders. And now we have this bidirectional interactions, right? We know that on the one hand, epilepsy can worsen sleep and cause insomnia, other sleep disorders. On the other hand, we know that disorders of sleep, and here I just listed the common ICSD classification diagnosis, can also aggravate epilepsy. And then we have a very fascinating differential diagnostic spectrum between non-REM parasomnias and sleep-related hypermotor epilepsies. And here comes into interplay my love for epilepsy surgery, that evidently these different vigilance states are very, very important if we think of developing biomarkers outside of seizures. But that's just to show how important that is. And that is something that is very well known for a long time. But then again, there's always the way, how can we use it? And what I will talk today is about how can we use EEG to study sleep and epilepsy. There's different things you can do, right? This is what usually sleep folks do. They have a polysomnography with a limited coverage of EEG, and that's how sleep in a sleep lab is assessed together with other markers for EMG and respiratory function. But then, particularly for epilepsy, it's really mandatory to not only do the standard polysomnography, but to add additional full 1020 EEG. Or what we can do in addition, that's what we do in research as well. You can use high-density EEG plus polysomnography and use up to 256 channels on the scalp. Or finally, you can do something that looks like this. And this is a combination of simultaneous recording of polysomnography and intracranial EEG. Again, we are limited to 256 channels due to the amplifier capacity. Okay, so, and what I will focus today is really this. Then I will first explain why I think this is the most appropriate and best way really to study this phenomena. Because there are certain limitations of the scalp EEG. So the scalp EEG is really great, but at the end, what we record in the scalp, it's all a blur. And I will explain a little bit what are the issues. And one really important issue is that scalp EEG is lined to focal deep-seated epileptic discharges, or also if you have very small sources below 4 to 6 square centimeter, you likely can't record it on the scalp. And this is why when we have our patients implanted, the best way is then, in addition to add simultaneous polysomnography, meaning you have scalp electrodes for the sleep recording, EOG, and then EMG chin, and if possible, tibialis anterior muscle. And evidently, it would be perfect to add all the respiratory functions, but usually that's not so possible. But this was one of the papers which really drew my attention, and that was at the time basically when I was deciding on becoming a neurologist. And basically what I found very fascinating there, that's work from Beth Malo, who did a lot on this topic at the time. She now moved to autism. But what it shows basically is here, so that's the first episode and second, and what we can nicely see here, that the seizure starts, right? We have here this low voltage fast activity discharge that's going on. However, if we look at the scalp EEG, that it's really only a couple of seconds later, right here, when we see the movement artifacts that the patient awakes. And so it's really fascinating because from a scalp perspective, we have the impression, okay, there is an awakening and then we have the seizure. But indeed, very often and in most of the cases, and I will show evidence for that later, it's that the seizure already starts in the brain, and secondary to the seizure, we have then the awakening. And I think that nicely really shows that we miss a lot of information if we are only focused on the scalp EEG. Now, also for the learners, one slide for invasive intracranial EEG, and here for those interested in the topic, it should come any day now, a seminars in epileptology article that we published in Epileptic Disorders, and which explains and really shows, I think, 60 figures, a couple of videos, a lot of teaching material. So in epileptology, we use intracranial EEG for pre-surgical epilepsy evaluation, more precisely for the phase 2 workup. And it directly reports neuronal activity from the cortex, and that's just the major indication to define the seizure generator, to tailor the surgical resection, to map cortical function, to examine the relationship between lesion and seizure focus, and also determine post-surgical prognosis. And now, and that's a very exciting field, and for cranial EEG, now we can even use it directly for treatment if we think of thermocoagulation, for example, that we can do directly adjacent to that topic. And Then there was a lot of discussion. I don't want to go into that there are different methods consisting of the staph electrodes. I show some examples later of both stereo EEG versus cortical strips, but whereas stereo EEG is something used for many decades already in Europe, it's now the predominant technique also in the US over the last. Now, actually, what's fascinating with this SVG is that we get a three-dimensional picture of the brain. And so really to understand what we have, we need to very carefully co-register the cells. And this is an open source plugin that I developed together with Minat Selman, who is now at the NGH, but during the time we were together in Montreal at McGill. And that's basically an example of such a commercially available SVG electrode where you can see the contacts, and these are the reconstructions, for example, where then at the end you can get coordinates for every single of those contacts, and now that you can put it in different atlases, templates, pull all the data together for analysis. It's really something very interesting. Now, that's the combination that we now also set up here at Duke, how we record that together. So this is just a very small selection for illustration from intracranial EEG channels. But then we have here our scalp EEG, chin EMG, and then the flexor digitorum superficialis that many years ago we could show is very well suited to detect REM sleep behavior disorder, REM sleep without atonia. But just to make the point here, so a 30-second epoch of sleep, right? Sleep is categorized in this 30-second epochs. Now, if you ask me, is that the way a human system works? No, but at least it's something that is feasible and doable manually. But what we can nicely see here is that when we look here, we have an epileptic spike here, fully spiked here in the temporal basal lobe. And, you know, there's nothing, for example, to see here in this EEG. Now, at that time, evidently, if we do SEEG studies, so patients are in the hospital a week, 2 weeks, so it's tons of data. And evidently, it would be good to not do what we do in the sleep lab to really store 8 hours every 30-second epoch manually. It's very, very time consuming. You have substantial inter-rater variability and probably even infrared variability. And so at that time, which is not so long ago, I discussed with one of my friends and I told him, you know, what I would like to have is I would like to have something where we can do fully automatic sleep scoring in intracranial EEG, and something where, if possible, we don't need anything on the scalp EEG and EEG, because a lot of places in the world, it's more complicated to get that. Why? Because the scalp EEG, infectious risk, a lot of reasons. And then the other thing is evidently in the intracranial EEG, these are not healthy people, right? These are people with epilepsy. There is a lot of epileptic activity, and it would be great if that tool could work, and we do not need to first define which are the normal channels, but we just can let it run. And basically that was the job. It's available open access, this tool. I have to say it really works very well. And that's just to show the overall agreement here. So this is the inter-rater agreement from two persons who are both certified in both in triple certified side neurology, sleep, and neurophysiology, epilepsy training at different centers. And you can see it's an unusually high agreement. Usually in sleep, it's acceptable around 70%, so very high agreement. But then when we looked what the algorithm did, and that was ignoring epileptic activity, and that was excluding it. And so basically, we really could see that we were around 80%, which is really very good overall. And then that's just for the different sleep stages. And as you can see here, it really works very, very good for N2 and N3 sleep, also for wake, even very well for REM if we consider that we do not use EOG, EMG in the equation of sleep scoring. It didn't work very well here in stage 1, but again, it's not surprising because you see even the raters had the lowest agreement here, and then N1 is something in between wake and sleep. So, but other than that, we were really very satisfied with the performance, and it's really something that can be used so that we can manage all this large data. And it's now in the meantime also used by a couple of other groups where we got positive feedback. So what I want to talk today is to understand the important bidirectional interactions between epilepsy and sleep, review the latest evidence on spatiotemporal effects of sleep on interepileptic activity, and then discuss the effects of sleep on seizure network dynamics. Okay, again, this is something for the trainees here. Something that is very well known and very well studied, that the rates of interepileptiform discharges and ictal activity is really not uniformly distributed across the sleep-wake cycle. So this here is all normalized for REM sleep, and what we can see here as well known and studied is that we have highest rates of ictal activity in non-REM sleep and the lowest rate in REM sleep. And then if we look at for seizures, right, that's given here. So we find that really REM sleep is prohibitive of seizures. It's only 1% of patients that we have found during REM sleep. Most seizures occur actually in stage 2 sleep here is 44%, as you can see here. But this is just from a meta-analysis and knowledge both from Salvi, Chi, and intracranially Chi, many papers put together nicely in 2013 from Marcus Eng and Milena Pavlova at the time. Another issue is that consequences of epilepsy and sleep are not well studied, which is quite surprising because 50% at least in drug-resistant epilepsy patients have sleep disorders. And the direct influence of nocturnal epileptic activity on sleep fragmentation remains poorly understood. And this is something we were very interested and investigated, whether sleep-related epileptic activity is associated with sleep disruption. And that's the first work we did, published in Annals by a previous postdoc in the lab, Peter Deret, who's now a professor at Lyon University. But basically, there are several interesting aspects that she found in that work. And so the first thing that was really interesting, I think nobody will be surprised that if you have a focal to bilateral tonic-clonic seizure or a generalized tonic-clonic seizure, that you will have an awakening, right? I think that goes without saying. However, in that cohort, what she found is that the majority of seizures, and many of them were even asymptomatic. That means there were no clinical symptoms except at the end of the seizure, some awakenings. And that here is an example. That's a seizure which arises from the right hippocampus, and there was a hippocampal sclerosis, the typical pattern with this rhythmic spiking activity, and then here low voltage fast activity, and then you see here the arousal. So a lot of these seizures, even so they seem to have no symptoms, they still lead to disruption of. So that itself is something that was not known at that time. And so the majority led either in awakening or in a lighter sleep stage, as can be seen here. But what was even more interesting is we said, okay, but what do spikes, right? Because as a general principle, usually neurologists, they don't treat spikes, they treat patients. And this is a good concept, but maybe we should still a little bit rethink, and maybe these spikes are not so innocent as they seem. And there are studies out to show that even during a spike, memory consolidation, for example, is started. And what we could find here in an association, and we had different time windows we analyzed. That's the spike index. And then we had a baseline time window, the pre-arousal time window, arousal time window, and the post-arousal time window. And what we could nicely see is that really in the time period before the micro awakening and during, we had a massive increase in spikes, as you can see here. And the same was true for bursts, which are larger spikes. So if we look from a graduation, so we have influences from spikes, then bursts, and then coming these seizures. So all of them have direct interactions with the sleep microstructure and arousals. And then we looked further into the data, and because we know there are different types of arousals, right? There are arousal that have more slow wave content, others which have more fast activity, and that was really very fascinating. So these are both arousals, same patients from M2C, where this is a fast activity arousal, this is a mixed slow fast activity arousal. And what is very interesting if we look here is that this fast activity arousal seems to suppress this epileptic activity, right? That you can see here. Whereas in the case of the slow activity arousal, you can see here a massive increase in epileptic activity. So we felt that's interesting, but again, these are just examples, right? So what is an example? Let's do some stats. And that's basically what we could find here. So we have here the power ratio for the to reflect the slow activity. So this is the slow frequencies divided by high frequencies. That's it. And this is the time zero of the so here. And these are the spiking rates in the neocortex and in the mesotemporal lobe. And what we can nicely really see is that at this time zero, really, as the slow activity really increases here, we also have a peak here in the neocortical spiking, so that we really can see a very, very nice correlation and association. Now, however, this is an association study. It doesn't prove causality. And this is work another postdoc in the lab who has now a university position in Lancaster University in the UK, was that she wanted to explore further the relationship between sleep stability, epileptic activity, and establish causality. And so she wanted to investigate whether sleep fragmentation and evoked arousals increase epileptic activity. And to achieve that, what we did is we directly manipulated sleep stability in these implanted patients using acoustic stimulation to induce auditory evoked arousals. And basically what we have and presented in the past were brilliant data, and now we're very proud that we could finally recruit our first patient to continue this project at last week, and all were fine with the setup. So now, what did we do? So we selected then for the analysis, we computed the global spike index, and then we had this baseline epoch. Then this is the epoch where the auditory stimuli with 1 kilohertz was applied over 5 seconds. And then in case an arousal, we took the first 3 seconds as the arousal epoch. These are all accepted measures. And then basically what we did is we compared this epoch in global spike index to this. So very simple, straightforward measure. So what we have is seven patients. And what we can very nicely see, as it's so low patient numbers for now, we really give the individual results. But what is really very, very well to see is that compared to baseline, there is a massive increase here, really a large effect on this global spike index, which kind of confirms that in stable sleep, likely if we were to treat it, maybe that would contribute also to improve epilepsy in general. So now to sum up this first part, epileptic activity disturbs sleep structure. Even subclinical seizures and bursts of epileptic activity disrupt sleep. I also showed that sleep structure impacts epileptic activity. So arousals are able to enhance epileptic activity. And this is really something where we will soon start also a project here at Duke, where we try a new medication for sleep stabilization, and then really see is that a way to control epileptic activity and seizures. That's an avenue that has not been undertaken so far in epileptology. Now, I will talk about the latest evidence on spatial temporal effects of sleep on epileptic activity. So that you all remember, and I talked that generally spoken, spikes are more frequent in non-REM sleep than REM sleep. But yes, it's not as simple. Nothing is simple in life. And indeed, this is the first work actually from the group in Marseille, published in 2018, where they could show that it also not only this statement is generally true, but it also depends on the region. And let's for now just focus here on Canada. And what we see here is, again, the spike rates. Here, these are the different regions: thalamus, parietal lobe, occipital lobe, mesiotemporal lobe, lateral temporal lobe, frontal lobe, contralateral mesiotemporal. And then we have here the spike rate in non-REM sleep. It's the darker green, and the lighter green is the wakefulness. And you can see really here that most difference between non-REM and wakefulness rates are seen for the mesiotemporal lobe, and that is true both for ipsilateral as well as the contralateral side, which is something that was interesting and has not been described so far. But then again, it's also something we see in our everyday clinical doing, that particularly in temporal lobe epilepsy, spiking is seen during the sleep much more than during wakefulness. And I think that's much more seen for temporal lobe as opposed to other types of epilepsy. And here it could be nicely shown. So medial temporal structures showed a greater propensity to spike increase compared to other brain regions during non-REM sleep. And this increase of injected spikes was mainly the result of a local spike reduction. That's what it showed. However, that doesn't answer the full picture, because we don't know if the spike or epileptiform discharge suppression in REM sleep differs also depending on anatomy. And then there were first studies out more recently that claim that there are novel spatial coordinates exclusively to REM sleep, something that I did not understand how to explain that from a physiology point of view. The authors neither, but we will come back to that later. But it was reported, and there was some hype around it. And then what we also know, and that's work we did a couple of years ago, is that spikes generally are less prevalent in the phasic compared to the tonic REM sleep. So I think, and we can have a talk on that separately, but there is not one REM sleep. I think it's fundamentally wrong. I think that REM sleep is two separate states which have different function, and it's the one phasic with the rapid eye movements and the one outside of that states. And so basically, we know that in the second half of sleep, we have more phasic REM sleep, and therefore it's likely that spikes are lower in the second REM sleep. But that were the assumptions we had, and this is a project that Alissa Ho, who is a research associate now here at Duke, who joined the lab during her master thesis in our lab at McGill, where she looked at 40 patients. That's basically all the electrodes we had available here on the transparent brain. And then on the map, that's the number of channels we had available for all the different brain regions. And generally, it's always good to confirm what is known, just to be sure that the algorithms really detected what we wanted. But we could confirm that spikes are higher in non-REM than REM sleep, independent of the location. Well, that's not very exciting. But what's most exciting is that really here, if we look the change in ID index with respect to non-REM sleep, we have the neocortex, the mesiotemporal lobe, and we could see that there was more suppression in REM sleep in the mesiotemporal lobe. And this is quite a good effect size if we think of biological processes and electrophysiology. So it's not just statistically significant, but really clinically meaningful. And then we looked at the different regions, and we could find that across the brain and independent of presence of seizure onset zone or non-seizure onset zone channels, there was this global suppression of REM sleep, maybe a little bit less pronounced here in T1 and the Heschel gyrus and the cingulate gyrus. We also were interested to know how is propagation behaving, because usually we have a larger field in non-REM sleep and a more restricted field. And what she could show that independent of if it's seizure onset zone, non-seizure onset zone, all channels, propagation was dependent on sleep stage, but we couldn't find a difference that was significant between mesiotemporal and the cortex. Now, this is also something that nobody has investigated in that detail so far, is we have here the REM IED rate embedded, and then here we have a ratio between REM, non-REM IED. And basically, we have here our threshold, and the SOC channels are in red. And what we could find that basically everything above that line means it's more present in REM sleep than in non-REM sleep. But basically, what we could find that only a minority of channels had higher spike rates in REM than in non-REM. And it confirmed also our hypothesis, and we are around here. So the threshold, we used the phase positive detection rate, what was reported in the specific detector adjusted for the sleep stage, that we didn't find new coordinates during REM sleep, which confirmed what was our understanding, but contradicts what these studies from electrical source imaging were showing. So that led then to another work where we said, okay, let's do our own electrical source imaging study to see whether we can confirm or not confirm these past findings. That's work done with my collaborator, Birgit Frauscher, who visited a couple of weeks ago, or months it's now already. And then a PhD student in the lab, Tanya Avicto and Shifa Abdallah, and basically 16 patients, overnight sleep recording. And then we selected spikes from all the different sleep stages. And I will not go in the methodology of source localization, but actually the technique is now much further advanced, right? We don't need to look at the EEG in the conventional sense, but we can create this very, very nice pictures and have it like images. And so, for example, in that case, we could nicely show that the source of the spikes here is in the anterior temporal lobe, and also, as you can see here, in the hippocampus. So basically, what we wanted to do here is to see, does the maximum activation as well as the field change across the different states? And I will not go in the stats, which really will prove the point, but I will show an example, and I just have that here so that people really believe what I say. But the point is here, if you look at it, then you see that these 4 source maps from the same patient and 2 and 3 REM and wakefulness look really the same, and the same as if we look at the sensor map, basically. So we couldn't find any new coordinates in REM sleep. And so basically what we think what could have happened in these previous studies might have been either that they were maybe influenced by some noise, because it depends if you do source localization on 1 or 2 spikes only, there can be some noise. It might be that we use the technique that is very sensitive to the spatial extent and is very well able to recuperate it, or small sample sizes in the one study with 5 to 6, or doing source localization in low density with 25 channels, which evidently is less accurate. You should use at least 64 channels or more for high density source localization. Now, also epileptic activity distributed across the night, and evidently we expect that rates differ, and the highest in the first half, and that's work that we did a long time ago. And what we basically could find there, that delta powered sleep slow waves, as well as this phasic REM sleep with the rapid eye movement, are differently distributed across the night, and that they have different influences on epileptic activity. So, for example, we could find in this publication here in grade that it's really the higher the amplitude of the slow wave is, the more epileptic activity you have. And here we could find that during phasic REM sleep, you have significantly more suppressive activity on epileptic spikes as opposed to non-REMs. But then also it's the whole night, it's the time, we can go down the different sleep stages, different sleep cycles. I will, to respect time, not go in detail with this, but basically I will show just, this is again an example, the stats were shown before, but what we could nicely see here. So this is another comparatively new biomarker of epilepsy, which is called HFOs, which are defined as oscillation events above 80 Hertz, and there we have those between 80 and 250, and those above 250, which are called fast ripples. And then in these ripples, we have both pathological as well as physiological. And what we can see here is that the physiological ones, they seem to increase across the night, as we can see here in the REM sleep. Whereas the pathological ones show a decrease from the first non-REM sleep cycle to the latest non-REM sleep cycle. And the same was also true for fast travel. So it's even more complicated. It's not only a matter of the sleep stage, but it's also a matter of sleep homeostasis. We have circadian factors. And we know in the meantime with RNS and other techniques that we have even periannual rhythms. So there are patients who have rhythms which is once a year with seizure rhythms. Others, they have it every couple of weeks, every couple of days. Now, that's also work from Alissa, but also Katharina in the lab, where we could then show that spikes are higher and early compared to late sleep, and that the suppressive effect of REM sleep was greater in late sleep compared to early sleep. So now sum up the spatio-temporal effects. So spike suppression by REM sleep differs depending on anatomy. It behaves differently whether it's mesotemporal or cortical. REM sleep restricts the spatial exchange of spikes and can thus be important for precise localization of seizure fruits in epilepsy. And we didn't find any novel spiking regions during REM sleep. And then also the rates of epileptic activity depend on the time spent in sleep, with higher rates in early than late sleep. So high sleep homeostatic pressure, more epileptic activity. Now, in the last part, I want to discuss. So far, we talked a lot about interictal activity, but we as neurologists, we're interested in seizures, something that we can see and observe clinical symptoms. And now let's discuss the effects of sleep on seizure network dynamics. And so basically that is what was out, and I'm sure many of you know people here who did that publications, but what was known is, yes, seizures are more frequent in non-REM sleep, particularly in acute sleep and wakefulness. Yes, seizures in mesotemporal epilepsy generalize more frequently in sleep than wakefulness. And it was also shown, interestingly, and maybe a little bit surprising if you think about it, seizures are not longer in non-REM sleep. Wakefulness, right? My first guess would have been, we know we have all this synchronization effect by the non-REM sleep, and due to that, I would have personally expected that maybe then the seizure is more intense, which goes very long along with this, that we have more generalization during sleep in mesotemporal epilepsy, but maybe also longer. But that's what was out in the open at the time. But the effects of sleep on seizure topography were fully documented. That's work that Sana did, that we published earlier that year. And so we really wanted to very carefully characterize seizures during non-REM sleep and wakefulness. And so we had 25 patients with seizures during wake and non-REM sleep, and we selected them within a 24-hour period. Why? Because usually when patients are here for post-surgical evaluation, we taper drugs, and we wanted to eliminate the effect of anti-seizure medications on our findings. So that's why within 24 hours, with the assumption that usually the blood level should be pretty similar. And then we looked at different features here for the ictal state. We looked at how the seizure starts, or the seizure onset pattern. We looked at the epileptogenicity. We measured the fast activity content at seizure onset, and then we looked at the spatial temporal propagation, and then also as a kind of control marker, we looked into ictarian spikes. I will show that. That's basically the markers we did. It was a lot of work, as everything was marked manually. For the future, we plan to use algorithms to detect that, but in that work almost done manually. Basically, on a channel-to-channel level, the seizure onset was marked. And those who read, from the fellows who read SEG, they can imagine that that's a lot to do that. So that's the onset of the respective seizures. Then we mark the offset, and then we determine the seizure onset patterns, which is this beginning here. And then we also looked for the recruitment of new channels within 500 millisecond windows, as you can see here. And so we have different clusters.
મને કન્ફર્મ કરીને કહેજો ને કે તમે આજે આવશો કે કાલે એમ તો તમે કાલે આવશો તો પણ વાંધો નથી પણ કેટલા વાગે કાલે આવી શકશો એનું મને કહી દો તો હું તમને મૂકવામાં
Okay.
આવીશ.
So then what we found here is that seizures simulant wakefulness and non-REM sleep, and spatial distribution of seizures was not at all affected. And I will show you the results to really convince you that it's really the same and there was not even small effects to be seen. That's just a kind of a map, an illustration to show it's the same patient. It's a seizure in wake, another seizure in wake, a seizure in non-REM, and another seizure in non-REM. And evidently, we are all know that no seizure looks exactly the same in sheep. But what you can nicely see here, we have here the different channels and electrode names, and here the time. And then we have the early clusters are more red, and then the late clusters more dark. But we can nicely see that if we look at it, these pictures look pretty similar across this state. At least there is no meaningful significant difference. And here we have the numbers across all patients, wake, non-REM, and that's the percent of channels in the seizure onset zone. We even then subdivided between temporal, extratemporal cases, but it was the same. So I will not further go on that. But as you can see, if we look here at the variance in the box plot, really very, very similar, and then the same, the total number of channels involved in the seizures, no difference at all. Then we also looked at the spatial temporal propagation, and so we looked at the duration. As shown in the SCALP study, we found there was no difference between the vigilance state. We then checked also the latency to the maximum channel involved, but no significant difference. The number of propagation clusters, no significant difference. And then the mean difference in cluster onset time, again, no significant difference in all that measures. Now, that's another map that we generated. That's the epileptogenicity of brain regions during seizures. And we also found it's not affected. And that's also two seizures. And you can see if we just look at the map, here is the different anatomy here with the electrodes, the time. If you look at them, they are pretty superimposable, I would say. And then if we look at epileptogenicity index above 0.3, which is highly suggestive to be inside the epileptogenic zone, then we also could identify here the same targets on both cases. Now, again, here's some stats of the whole patient group. So here are, if we provided the channels with an epileptogenicity index above the threshold of 0.3, the same here. Also, if we look at the correlation, we found that there was no difference between the intrastate, meaning between one seizure and the other during wakefulness or non-REM sleep, as opposed to between sleep or interstate correlation, as you can see here. And this here is just, again, a similar distribution. What I think is very interesting here is that for spikes, as we showed in the previous slides, what is nice here, we have here, these are all the electrodes, and then low activity. Here we had spikes in wake or non-sleep. And the red is where you have it in both. And what you see, there is a little red and more blue. Whereas if we look at the seizure, we have a lot of red, meaning that really the behavior in seizures is very similar, independent of the state of vigilance, but that's not the case for the inter activity. And that's again shown that the effect size here was really quite remarkable, the 0.5. So what we concluded is that in contrast to its effect on spikes, non-REM sleep does not affect the spatial temporal dynamics of seizures, and that suggests that once the brain surpasses the threshold for generating seizures, it will follow the underlying network irrespective of the vigilance states. And we believe that these findings offer valuable insights into neural network dynamics in the epilepsy. Now, I want to sum up and conclude. I hope I could convince everybody that sleep is an important modulator of epileptic activity. Sleep and epilepsy have important bidirectional interactions. Sleep is not uniformly affecting epileptic activity, but there are important spatio-temporal effects. And then the effects of sleep differ between ictal and interictal network dynamics. And with that, I would like to thank people in the team, funding, now particularly my startup here at school that currently pays for all research activities here for the moment, and you for your attention.
Thank you, Birgit. That was great. At the end, I had a coffee emergency as I launched my coffee cup all over the rug here. So I went transiently incognito. So any questions? Just put your name in the chat. So I have two questions. One is 2 phases of REM sleep. Is that something people knew about, or is that something new? And the second question is the relationship. I know there's a long story of memory loss in epilepsy patients. Do you think any of this sleep effect could be related to that?
Yeah, these are all good questions. I need to say that REM sleep has these 2 components, the phasic and the tonic REM sleep. It's a concept which is discussed less so in the clinical community, but more so in the neuroscience community. And I remember last year in Athens at the European Sleep Conference, there was a hot topic symposium on this topic. And it's really something that is very fascinating and also interesting for clinic, because what I showed today, I talked about epilepsy, right? And so in the phasic REM sleep, we have really the lowest rates of spikes. And so, and because it's the most cholinergic activation during this time. But then also it's old work that we did. It was in 2008, old work that we published at that time for REM sleep behavior disorder, where we looked where are indeed the movements in REM sleep behavior disorder occurring from. Is it the phasic or the tonic REM sleep? And we also could find that it's the phasic REM sleep. So there are differences, and then there are also differences like how well you are arousable from one state or the other, functions for dreaming, etc., etc. So in general, people feel that the tonic is much more similar to the wake state, and then also neurophysiological, there are subtle differences. I mean, I just saw so far prelim data from Tanya in the lab. Hopefully, we will have that soon. That we might have more fast frequencies also in this phasic REM sleep as opposed to tonic, but it's an old new world that is now coming up.
What about dreaming, Birgit? When does dreaming have any relationship to the 2 phases?
It's a little bit hard to say, and because the thing is, like, how do you study dreams, right? You can awake a subject and then ask, did you have a dream? That's what a lot of the dream researchers do. But then the thing is, like, this bursts of phasic REM sleep, they are short. They're just a couple of seconds, you know, they are intermixed. It's totally intermixed, one and the other. So I think it's a little bit difficult, but maybe others have better answers to that. But so your other question, it's a very hot topic as well, and also work that we started and others started to study, where basically we can see if, because there is this sleep-related memory consolidation, this is a phenomenon that's very well known and very well studied, but now the question is it because the sleep is so disrupted through the epileptic activity, particularly in people with temporal lobe epilepsy, might that further explain that the sleep-related memory consolidation cannot take place? Now, we did a review article on that together with Katharina Schiller and other neuropsychologists in the lab 2 years or so ago. the evidence so far is not great because the studies are very heterogeneous. The sample sizes, you need quite a bunch of a good sample size because the effects are not large or moderate. It's smaller effects. So we are actively working on the topic, but it's a complicated issue and very interesting. And then also if we go away from the sleep, but in general, if we think about another hot topic about epileptic activity in the mesotemporal lobe of people with Alzheimer's disease, it's also something that is very interesting and a hot topic over the past years in epileptology.
So I will turn it over to Felix to ask for the last question. But Birgit, I would suggest, why don't you just do a spinal tap on all these folks or get some spinal fluid and send it to the Mayo for AD biomarkers. So you could have that. I mean, you folks must be awash in spinal fluid in these folks, I would think. Maybe not. But we could help you with that because I was thinking the same thing. Felix, take it away for the last question.
Oh yeah, thank you for the talk. I'm just curious to know how easy it is to, in a way, simulate REM-like behavior in a patient who is in non-REM sleep and having a seizure with some sort of stimulator, in effect trying to create like resistance to seizures while asleep, since that seems to be a major difference between the sleep phases, that is the non-REM and the REM phases.
I'm not sure to really understand the question. Are you asking how likely it would be in those who have the electrodes implanted to give a stimulation when a seizure starts? Or
Yeah, so you did mention something about the auditory evoked potentials and like,
Yeah.
just ways of like stimulating to increase like the spike density. I'm just wondering if there are ways of actually transitioning the patient from a non-REM phase to a REM phase, essentially to abrogate like a seizure activity in someone who potentially is detected to be having seizures while asleep.
So Felix, you're saying if you could flip a switch and their brain would go from REM to non-REM to abort the seizure.
Yeah, like from non-REM to REM, correct.
Yeah.
That's a good question. Not easy. We published, I did show it earlier this year, a paper in PNAS, where we looked at the transitions in intracranial EEG between non-REM to REM. And again, it's not an all or nothing phenomenon, but it's also a gradual process that goes over time. That's the one thing. It's not like direct switch. It's a gradual thing, and certain regions in the brain start earlier or later. I think the more posterior ones start earlier, but it's a very interesting thought. I'm not sure that is possible, but what definitely, and that is what they started also trial with the chronic modulation, is independent of the state of vigilance, that if a seizure starts in a region, you could stimulate to then abort the seizure. That's what's the concept, at least behind the responsive neuromodulation in chronically implanted. And I mean, at least something similar can be done if you stimulate for seizure or functional mapping a patient, you can stimulate. And then if you are early on, that's old work, which is the pre-work for then this RNS concept, is that if you give this stimulate early, then you potentially can abort a seizure. But the concept to stimulate and then get a transition from non-REM to REM, I'm not aware that that's possible, and I would think it's not possible or extremely difficult. I would not know how.
All right.
Thank you.
All right. Thank you, Birgit. Thank you for a great talk, really stimulating. If you don't mind me asking a question for the young folks, I mean, there have been electrodes in people for, I don't know how many years, 30 years. How come nobody really took on the issue of sleep until relatively recently?
That's a very good question, and I mean, I can just give you my view. That doesn't mean that's the ground truth, right? It's an opinion, but I think that in the very old days, sleep and epilepsy were joined, and in nowadays, it's two different fields where most people don't speak the one to the other, and it separates entities basically that function totally separately, and they have different educations. Even as you can see in the US, it's not the same fellowship. And so there are very few people who are board certified and trained in both. I'm one of them. There are a couple of them, but generally it's not like that. And so I think that for these electrodes implanted, the people who do that, that's those who are interested in epilepsy surgery. And their research is then on biomarker development and not that much interest of sleep, but there were a couple of people who had that interest, like when I was young and I wanted to go.
Okay,
and,
you're still young.
well, yeah, that's good too. But yeah. But you know, there were like people like Jacques Mauplaisir in Montreal, but he came from the sleep field and then just used this
that's
SEG
interesting.
recordings to publish, and then some others like Lino Nobili, Wes Marlowe at the time. And now it's becoming more and more popular, I have to say. There are now several groups who do that, and now even the epileptologists contribute more importance to it, because if we look now at interictal biomarkers, it's actually important to look at the different sleep stages.
It also might relate to the funding agencies too, right? Like the epilepsy people may say, well, what do we care about sleep? And the sleep people might say, what do we care about epilepsy? So, you know, but it's an interesting idea, right?
Yeah,
all right, everyone. Thank you. Thank you for the talk. Thank you for everyone attending, and be warm today. Bye-bye.